preventive, we have laboratory, we have outpatients. We have a special clinic for diabetes and hypertension. We call it lifestyle clinic. TB clinic, health education. We also refer for the cases that we cannot be able to manage. The community refer for us, and then now we're able to refer the next level, but only if you're not able to manage. We also have gender-based violence. So for maternal health, we give immunization, we do growth monitoring, we have nutrition, antenatal care, postnatal care, we do family planning, we do cervical cancer screening, we also do nutrition. And for our mothers who come, we give them Linda Mama so that when they're giving birth, they don't pay. It's free of charge. It's a kind of insurance. Yes. And everything is free. All our services is free.
Habari.
She's
Grace.
Grace. They are HTIs counselor. HIV counselor. They do counseling, they do testing. Yeah. So what else do you do, Lynette?
We offer prevention methods like PEP and issue pregnancy.
What's the percentage of the population that's HIV positive?
Yeah, we issue also ART. We start them with that for the HIV positive.
What proportion of the population? Out of 37,000 people, how many are HIV
positive? Current in care.
Current on care. Cohort. 786 on care. Yes. But you have many clinics around.
Yes.
But currently here on care, I also get that number.
And do you think there's a lot undiagnosed?
We are trying to reach them. Yeah.
Right. Yeah. One of your average patients.
Yes. So what do you do to reach them?
We do like medical camps, we go out for outreaches. We also target those that are already on care here to get their sexual partners and also their children for testing. So we'd go to their homes to do the testing, or we'd also invite them here to come, either on a weekday or also on a weekend.
Okay.
We avail ourselves so that we can be able to reach to all of them. Yes.
Very good.
The person who is infected gives you a number, then you follow.
Yeah, we follow up on the
Yes.
And what does you said you offer counselling as well? Like, what does that look like?
The counseling that we offer, basically it's for HIV. We prepare them for the test in the beginning before we conduct the test. Then we conduct the test. At the point of preparation, we also want to get their feelings on how they're feeling about coming for the test and what they're expecting the outcome to be. And when the results comes out, we also address the issues. We address their emotions at that point. We want to know what they're thinking, what is going on through their mind. If they're crying, we want to know why you're crying, what does this mean to you. So we do it's a first aid kind of counseling here before we take them to the adherence counselor. Now that one, she deals on the issues of the drugs and also does more of psychological counseling now. And because getting HIV is also a loss, we consider it as a loss, so we also want to deal with it in that aspect.
It all helps. People realise anybody
Yes.
vulnerable. So other than that, I think some people come forward and they become great advocates. The guy who spoke, I can't remember who spoke, but he was ex-armed forces, and he was found through the opt-out testing.
Oh, okay.
It's nice.
Do a lot of the patients that you treat here also have TB?
Sorry?
A lot of the clients that you have here, your patients, but for HIV, do they also have TB a lot of the time?
Not all of the time, but sometimes. Sometimes they do. Yeah. Co-infected TB.
Yeah.
Yes.
And which do you tend to find first, TB then HIV?
Yeah, some come
They
with
come
TB.
with a cough.
Yeah. They come with TB. Now when you go testing, you realize, oh, so she is also having HIV.
I suppose if you are doing outreach to find HIV positives, that's when you'll find the latent TB.
Yes. And then now we have our data room here.
Whatever we do in the community, we combine the
Yeah.
data.
Also climate change means
So that,
But this shows we should do a bit more outreach.
yeah.
Yeah.
At least per quarter we go maybe 1 or 2, depending also with the funds.
Yes.
So we have something we call quality improvement. So we have a dashboard. We have projects that we do, active projects. We have around 3. So we picked one project and then we give them like 3 months and then we review again.
Okay, for now we are doing active case finding for TB. Yeah. So we have a screener, a triage, who always screen all the patients who are coming in. Then if a patient has a cough, or we can say if a patient, or the patient who are URTI, we have a presumptive register in consultation room. So we always document them there. Then we send them to the lab for the test.
He's a nurse by profession. Yes. Godfrey lab visitors from UK. Yes. Yeah. So maybe you tell me a bit of what type of clients you see. Majority.
okay, here we see maybe under 5, mostly pneumonia and diarrhea. Those are the majority cases and the common cold. Then for the adults, maybe HDN, diabetes, and respiratory tract infections. So
Yes.
Is there a high rate of diabetes?
Sorry?
Is there a...
Not so high, but hypertension is high.
Going up.
Yeah, hypertension is very high.
Okay.
Yeah, compared to diabetes,
I see.
this one is higher.
I see.
Yes.
So you did see an increase in the in cancers and heart disease.
okay, now those ones, mainly we don't really do them here because we refer. So when
Okay.
we do such a
Yeah.
case, when it's quite complicated, we refer to
Yeah.
others. They are managed.
Yeah, so it's pretty more like our GPs.
Yeah,
just like our GP.
Yes.
Yes.
So a bit wider. Yes. Yeah.
Asante.
For maternal health, we give immunization, we do growth monitoring, we have nutrition, antenatal care, postnatal care, we do family planning, we do cervical cancer screening, and also do nutrition and counseling. We also have NHIF. For our mothers who come, we give them Linda Mama so that when they're giving birth, they don't pay, it's free of charge. It's a kind of insurance.
Again, within the counties, we do have the counties that have more rural-based feel, and then the others that have more urban feel, and then there's a mixture. But you do have the cities, that is Kisumu, Mombasa, Nairobi, that they're quite unique compared to the other counties. They're unique because the population within the cities, they actually work for a living. So again, in terms of operating of the health facilities, it becomes different from the others. So if you go to the rural area, it opens from 8 to 5. But in the city, the mothers go to work at 6, they come back at 6 p.m. So you see, they are not captured within the 8 hours. They are not accommodated within the 8 hours. So we look for ways of looking how to accommodate those mothers who cannot come very early in the morning or in the evening. So how do we target them?
Karibuni. This is the nutrition room. When clients arrive, they wait outside there on the waiting day before they go in for immunization, because we have some coming for growth monitoring, vitamin A supplementation, others for immunization, and others for nutrition counseling. So before all the children go to other services, they pass here. So we weigh them. After weighing, we take their weight, their height, and their mark. And then we check for those who are malnourished. For those who are malnourished, we talk to them, and for those who need to be identified for management of malnutrition, we do so. So we have 2 programs here. We have the supplementary feeding program that we manage children who are moderately malnourished, and then we have the ones who are severely malnourished, we also have a program for them where we give plumpy nuts on a weekly basis as we monitor them with the clinician. So once we pick out the ones who are malnourished, the ones who are well and are supposed to go for immunization, we now send them to the next room for immunization. But we have to check their booklet because some forget. They normally come with these booklets in this room. So we have to check for those ones who are supposed to be given vaccines. We refer them to the room. Yes.
Yeah, for severely malnourished children, we refer. Yes.
And for those who have complications.
Complications. But if you can manage here,
we don't manage.
give treatment.
Do the parents bring the children back when they're meant to bring them back?
Yes, yes. And when they don't bring them back, we do a follow-up. You call them. Yes, you have an appointment.
Now you've got mobile phones, it's easier.
Yes.
We record their numbers here,
Phone numbers.
and they come in. So if they don't come, we call them.
And is that booklet like a record of everything, every appointment?
This is now the
purple one.
This one, yeah, it has a record from antenatal care all the way to the child up to 5 years.
We have the
Yeah, so
book.
all that has information on what needs to be done to the child. It's a good information for the mother. Even it lets them know when the routine immunization the child is supposed to be given, which service they're supposed to be given at a particular age, what they need to observe in terms of their development milestones. They also need to record when the child starts smiling, when the child starts sitting. Those who are exclusively breastfed, they normally gain more than 500 grams in a month. That is the minimum we expect. So if a child is gaining less than that, we find out the reasons why. Maybe she's starting to introduce other things before 6 months. So after we confirm that the mother is doing the right thing, so we send them over for immunization. But we have to check because some are not, some have been sent to the child and not aware which vaccine the mother is the child is getting, so and then we have to refer them because if you don't refer, some may just decide to
So how often are they weighed and...
monthly. We weigh them monthly. If you look at our book here, it starts from
yes.
Yeah. This is the birth weight. This is the first one they came. This is how this runs to this count. So it is over to 5
And
years.
is it best getting between those two green lines?
Yeah, when the child is growing in between these two green lines, this is the normal weight for their
Just on the bottom of the norm.
If they start deviating towards this side, these ones we find that they are at risk for malnutrition.
Yes.
Those ones who are below this one, we find that they are moderately underweight. The ones who go beyond this dotted line, you find these ones are severely underweight. So you have to keep checking as they grow so that they follow this curve. So there is there are instructions here that also this is good, this is dangerous, find out why. This is very dangerous.
So I have a question. If a baby is suddenly on the red lines, do they have to come back earlier than a month?
Yeah,
or still only a month away?
We follow them up weekly.
Yeah. Weekly if it's on the red.
Yeah,
okay.
it is weekly.
Yeah.
So after we find they are starting to pick up, we go 2 weeks and then we go back to 1 month.
ICC inactivated. So I'll give it on the right side, 2 centimeters away from the pneumococcal outer. Then I think the last one is better than Rejection.
So we're in the middle of response, polio response. So Nairobi County is one of those counties that is participating in polio campaign, and the director will be able to tell us more about it. But I think from the visits, we've seen where immunization, how it happens, from the way to all the vaccines that are being administered. So what we do have was that the national government procures all vaccines, and the vaccines are funded through Gavi, the Vaccine Alliance. So we do have the traditional vaccines, and then we have the Gavi-funded vaccines. The traditional vaccines are fully funded by government and procured through UNICEF, whereas the Gavi-funded vaccines are still procured through UNICEF, but we are in a co-financing mechanism with UNICEF. So once we get them from the national, they're distributed across the country. We do have 9 regional stores serving the 47 counties. So from there, the healthcare workers can actually pick, store them within the facilities, and then we have full chain equipment across the 8,500 units facilities where the vaccines are stored. So vaccines are they are given free of charge to all the children, and we do have the younger children, we do have the adolescent girls, and then during COVID we had adults being vaccinated. So currently, not many of the adolescent girls to come to the facility. They're currently in schools. So what the healthcare workers do, they do organize and meet these girls in schools and vaccinate them. And then for COVID-19, not quite common, especially after WHO gave the recommendation that we are out of the pandemic. Yeah, so we only they get either people who are traveling and people having comorbid conditions. So there is a lot of linkages between the HIV clinic and the immunization clinics. And then we have, of course, the maternal vaccines. The tetanus are diphtheria vaccines, again, which are administered when mothers come to pregnancy. So in a nutshell, that is how what you've seen is what is mostly replicated across the other 47 counties. Of course, there are variations. There are some counties, the hard-to-reach areas where we have normally pastoral communities. We have extreme weather challenges, so the flooding, the droughts. Yeah, so again, they again don't come to the facility quite often. You find that they need to move from one place to another in search of water and pasture for their cattle. So again, the dynamics of the immunization program again can be reflected in those specific areas.
Yes, obviously if they are moving from area to area, the cold storage of vaccines becomes more of a problem because you don't know where they're going to be to actually have those facilities, the adequate facilities and resources there, and to make sure you've got enough vaccines in the location.
Yeah, so in those areas you find that the counties are very vast, so again the facilities are very sparse. So what we depend on, within their communities, we depend on immunization champions who can be able to track them in case they've not received a vaccine. They can be able to track their movement. If they move from this area and move to another area during seasons, they can be tracked easily so that they can finish all their vaccines. So I'm glad we have the county there.
One more question. I've seen a data that states that there's 12% of the population, and the 12% of infants are not vaccinated with any vaccine at all. So that means 88% have had at least one jab. If TB is still quite rife, is what percentage of infants actually get the TB jab? Do you know, or how many of that population actually immunised against TB?
Yes. So TB, we give BCG at birth. So most of the children receive BCG at birth, and we have at least 90 to 95% of these children receiving BCG. However, different counties have different uptakes of BCG. We find that in some counties it's lower than other counties. So for the BCGs to protect the children from the severe forms of TB, miliary TB, but after 5 years of age again, we do have TB predominant in some age groups. So we do have the youths, especially who live in congested areas, in schools. We do have those people living with HIV and AIDS again, prevalent in those areas. But the BCG should be able to cover again against severe forms of TB under 5 years of age.
I'm just trying to work out why TB is going up if they're vaccinated. Is it the ineffectiveness of the vaccine?
So again, I think BCG is one of those vaccines given at birth, and then
The coverage is usually very good.
the coverage is very good.
Yes.
But again, immunity wanes over
Yes.
time, and that there are underlying factors when it comes to immunity response and uptake in vaccination. So again, beyond 5 years of age, they are again susceptible. They can get TB, but not the severe forms of TB. So we do have County Director, Nairobi County. We're in her county. Again, she was busy organizing polio in the county, so she can perhaps introduce her team and also talk briefly about Nairobi County. Welcome, Dr. Carol.
Thank you so much, Dr. Rose, and good morning, everybody. Good morning. My name is Carol Ngunu. I'm the Director of Preventive and Promotive Health Medicine within the County of Nairobi, and I'm here with the head of the immunization program, Catherine, from the county. I believe you've also met the other team members, the
from
facility
sub-county.
judge and sub-county.
Yes.
Yes, so I think you've met them as you went around. Apologies, we came in late. We were actually we are launching the polio vaccination campaign tomorrow, so we actually had a preparedness meeting, and I'm glad to report we had 98% preparedness, so we are ready to launch tomorrow and just move ahead. And yeah, so for us, we get a lot of support from the Ministry of Health in terms of support for immunization programs. I know yesterday you were at the Rhodes Clinic and looked at the TB program, and we were actually just doing the media breakfast, and so I wasn't able also to join you, but my team was there, Mary and the rest of the team, and I got the feedback. And I know you've asked about why TB is still rife. For us in the city, it's just looking at what are some of the exacerbating factors: the overcrowding, the informal settlements. We now have the MDR strain coming in. There's still a lot of stigma around TB, so there are several risk factors. Our immunization coverage for 2022 for BCG, and that's the vaccine we give against TB, was 93%. So we still have a 7% of the population. We know effectiveness of these vaccines is about 80%. Yeah. So over the years, as they accumulate, then we have this population that really gets it but doesn't have the immunity, and so that's why we still have the burdens of these diseases. And for the TB program, we have a lot of community programs, and we really do appreciate the funding that comes into the country and subsequently to us in Nairobi County, because we are able to use some of these resources to actually have community-based programs. So within the city of Nairobi, we have 7,480 community health promoters. These are volunteers from the community covering all the 17 constituencies, having 100 households that they take care of in terms of looking at pregnant women, looking at immunization of the children who are born in those homes, looking at issues. If you have a cough, if you have an issue, then they'll ask you, have you gone to the hospital? So linking them to the level 2 and level 3 facilities. So I think here, how many community units do you have?
I have 100.
100.
No, 39.
39, so that's a total of 390 community health volunteers within this informal settlement of Kibera that actually links the population here. So the city of Nairobi has 12% of Kenya's population, 11% or so. So about 4.5 million people living within the city. And I think one of the issues that I really, talked to for the head of the national program is we are so unique as a city, and our challenges are so different. Yeah. And a lot of times we are asking, is some of this funding able to be focused on the urban population, focusing on what are some of the urban issues that are not really country-wide, they're just really for urban cities. And this is replicated across other cities also in Africa.
The rural ones have different issues.
Exactly, so completely different. The overcrowding, the movement, the lack of jobs, the kind of populations. We have key populations, particularly within the HIV spaces, the TB spaces, a lot of them within the cities. Looking at the working population of the mother, and you want that mother to come for immunization clinics during the weekday. They cannot not go to work because they have to pay. Yes. In the rural areas, they grow their food, so they have food. Here we have food insecurity. So a lot of issues within the urban cities. And so, I mean, when we get visitors like yourselves, we are happy that you actually come and see what are some of the issues happening within the cities. and looking at when we're discussing issues around funding, are we able to localize, put them in a context where we have some urban form of interventions that could be different from the other country form of intervention. So we are really glad for you to be here. We've done also quite well, and thank you for the support for the COVID-19 pandemic. I mean, it really just destabilized a lot of things globally, but for us as a city, one of the greatest wins we have is that we've done full immunization of 59.4% of every Nairobian living here. So we've been able to, I could say, compete with the first world countries a bit. But really we have issued the full vaccination coverage. So we've seen that improve, and in fact when we had the Delta variant coming in, we had a very low mortality rate compared to what was happening earlier. So I think these initiatives for us are quite...
It takes away some of the fear of immunisation, where there's been such a great success.
Yes,
misinformation.
And I mean funding streams then came down because it's no longer, it was de-escalated, but we've been able to integrate even within the facility. Though the one question we're struggling with, there are not very many vaccines for adults. So how do we get our adults to feel the need to come in for vaccination, because we are so big on children. Yeah, but I mean, we're trying to do integration, we are speaking to the communities, we are using our community health promoters to just say, you know, this is important. This was a lesson that the world learned, that this could happen. So if we have the interventions, let's take them up, because it reduces our morbidity, our mortality ultimately. But thank you so much for visiting us, and we are so glad to be having you going around to the city.
It's such a pleasure.
Yeah.
Coming back to when you were doing the COVID immunisation, were you able to immunise some adults from other diseases at the same time, or didn't you have the capacity?
So what happened is the main adult vaccines that we give are for tetanus, and then we have the COVID vaccine. So yes, for our pregnant women, the coverage has been really good, but also HPV vaccination. So what we did is we had interventions to also scale up. So at the same time, the national government was talking about HPV because so we actually did, and we had a very good working relationship with the education department.
Yes.
And I think for us that was a big win, because we're able then to have these vaccines given even at the schools. Yeah. So
when I was a child, I had all my vaccines at school. The nurse came to school. We all stood in the queue. And a different bum. But it was really very, very effective and very efficient, and my generation really benefited from that.
So I think that's also some of the lessons, the learnings, is that we must get education on board, and we must be able to speak to the children and their parents also at the school, so that it's not just a health facility which is, you know, associated with illness, but we are also now going into the communities, into the schools, and it's really worked wonders, particularly for COVID vaccination and the HPV vaccination. And so we are continuing with that integration, so within the facilities, but also having facilities. So we have this, as a county, we are coming up with a finance bill to ring-fence health financing funds, because currently any funding that we generate goes to this pool of money, and people want to do roads, others want to collect garbage. But we are actually just about to finalize our health finance bill to ring-fence the fund. So we'll be funding the facilities to be able to also do the outreaches. So this will be supplementary and also sustainable to the funding that we're getting also from our international donors. But we are just hoping to add, I mean, our populations are growing. The challenges on, you know, epidemic-prone diseases are also growing. So we are hoping that even as you visit us and understand our challenges, you can be able to direct some funding specifically to address some of those issues that we are having in the city. For us, our full immunization coverage is at 82% as of last year. We are hoping to do better this year. It was 81 the previous year, and because of COVID and people were avoiding facilities and feeling like if you go to a hospital you get sick, so it wasn't as great. So we are putting in place programs to try and bring it up to at least 90% coverage. So for the polio virus that was identified in Garissa, and now there are 6 confirmed cases in the country. So Nairobi being a hub, I mean the international airports are in the city. For Africa, we are one of the biggest cities, and you know the kind of traffic that goes through the city. So we are at risk, we are really high risk. Most of the referral hospitals are within the city, so the national government identified us to also take part. In 2021, we also found a polio sample in the sewage in one of our one of our settlements where we have a lot of refugees in Kamukunji. So and a lot of them come from Somalia, and similar case of what's happening in Garissa because of the bordering countries. And of course for them the immunization coverage is really low. So we are actually targeting 1,013,000 children within the city of Nairobi. So that's, I mean, about almost 25% of the national target. And so we've deployed over 5,000 healthcare workers. And these are nurses, about 1,500. We have about 1,000 community social mobilizers just to get the community coming. And we have about 1,500 community health promoters, as well as about 500 vaccine monitors, because we are monitoring also the utilization of this vaccine. So almost 5,000 strong of our city's healthcare workforces in the field. And we're expecting to launch tomorrow one of our informal settlements just to popularize it. We're doing media spots. We are talking to parents. We've engaged the County Directorate of Education. We had a meeting yesterday, and so we are saying we're going to go door to door, house to house, and all our health facilities, be they private, be they public, are all going to issue the vaccine for free. So we are hoping we get to that 1 million children. It's 5 days. It's a 5 intense day.
So during COVID, we actually trained a lot of vaccinators, a lot of volunteers, or people who could work in a normal environment. Did you do the same? And I using some of those to roll out the polio program over the 5 days?
So for the healthcare workers, we have about, I said, 1,452. So these are nurses and people trained on routine vaccination. So the city of Nairobi has about 4,800 healthcare workers. Already, but I mean mixed cadres. But for this campaign, we are looking at working with nurses and clinical officers, a few medical officers who will support us to go door to door. But for the mobilization aspect, because we have this team of 7,480 community health promoters, those are the ones we are using to do mobilization. Those are the ones we are using to accompany the teams and get entry. And we've trained them, and I really want to appreciate, because during COVID, we did a lot of trainings for these people because we had to go to the community. So they're the same pool of people that we're actually using during this campaign, and possibly for the next 2 rounds of the polio campaign. Yes. We are having community programs with different organizations that actually work with try to do disability inclusivity. And in fact, next week on Tuesday, we have a meeting with the United Nations UNFPA, because we are putting in some ramps at our biggest referral hospital, Mbagati, at the MCH clinic. In fact, I was just responding to the emails yesterday, and we actually have in the county, we have a program officer who we have actually just said, your work is to look at disability mainstreaming and to coordinate, because we are not 100% effective in terms of going to the community, but we are trying as much as possible. And even for TB, also TB program, to make sure we get to the communities nearest to them, but we're also making our facilities friendly. We are trying. It's a process. It's a process, because that definitely is a gap that has been there.